As we know, the pain is the most common symptom with which the patient comes to your OPD, and that is the main reason why patient doesn't go for surgery also. So how to control the pain and improve the ambulation and post-op physiotherapy is very important in these patients. In 1996, the American Pain Society included pain as its fifth vital sign with pulse, blood pressure, heart rate, and respiratory rate. So pain scoring is usually done normally on all the patients post-operative for such cases. Normally for pain control we use multimodal analgesia approach, which starts from the patient's preoperatively till the post-operative period. We give preemptive analgesia, neuroaxial anesthesia, or local infiltration, or blocks are given to these patients. In preemptive analgesia, when the patient comes to the OPD, mostly the patients are given gabapentin, and the studies have shown when we are using gabapentin or other analgesics preoperatively, the opioid consumption and the requirement of other analgesic systemic drugs is less. And normally these drugs should be started at least 3 days before surgery to get a good control or good opioid reduction post-operatively. Normally all the knee arthroplasties are done under neuroaxial anesthesia. We are doing here mostly under spinal anesthesia. And in the spinal anesthesia, to prolong the duration, we are adding opioids, alpha-2 agonists like clonidine, dexmedetomidine, which prolongs the even analgesia post-operative by 3 to 6 hours. Prior combined spinal epidural was used and the epidural was used post-operatively to control the pain. But the use of epidural has reduced with time because it causes urinary retention, especially in old age patients. You see a lot of UTIs are common when you go for catheterization. They have got multi-medical problems, they are diabetic, hypertensive, so many comorbs are there. So in such cases the epidural analgesia is not so much advocated. Then neuroaxial complications like hypotension, spinal intrathecal punctures, that can happen. That can all be avoided by using the nerve blocks nowadays. The other disadvantage of epidural was that motor function recovery and rehabilitation of the patients was difficult. Intraoperatively, the surgeons can help, or they can what they can do to reduce post-op pain is by doing local infiltration analgesia in the posterior capsule or collateral ligament or capsular incision sites. Even in the subcutaneous tissues they can do the infiltration. Normally the cocktail is used, and what we are using here is ropivacaine, that is local anesthetics, plus opioids like morphine, 1 ampule epinephrine, clonidine or ketorolac. Ketorolac we normally avoid in patients who have got CKD or renal problems where you can't give NSAIDs. We try to give clonidine. This is for per knee. So you can give for 2 knees, you can make 2 cocktails and you can give for each knee. And the infiltration should be done very generously in the posterior capsule, because if you see, before I tell you about the nerve blocks what we use, the important thing is to know the nerve supply of the knee joint. The knee joint is anteriorly supplied by the saphenous nerve cutaneously and posteriorly by the sciatic nerve, which divides into tibial and common peroneal. And its terminal branches or main superficial branches are like genicular nerves are there. So what we are using is, most commonly we are using is adductor canal block, which blocks the saphenous nerves. But saphenous nerve itself has a disadvantage that it covers only anterior-medial aspect. It doesn't cover the posterior capsule of the knee. So for that the local infiltration becomes very important, that it should be given very properly in such patients. But the advantage of adductor canal block is that it provides early ambulation and you can avoid all the neuroaxial complications. In our center we use adductor canal block with catheter. So you can give for 48 hours of analgesia in such patients. You can use deflatable balloons or you can use PCA pumps to give adductor canal, continuous adductor canal block. In adductor canal block, the studies have shown that if they significantly decrease pain over 48 hours when you use continuous adductor canal block. Single shot adductor canal block can also be given, but in such cases you have to add some additives like opioids or alpha-2 agonists like clonidine or dexmedetomidine. Previously, and some centers have observed, the people are using IPAC block, that is infiltration between popliteal artery and capsule of knee. But the problem with that block was that it has to be given preoperatively, and you cannot give continuous block. So this technique has reduced over a period of time. Some people are still using femoral block and sciatic nerve block, but the disadvantage of this is that it causes quadriceps weakness. Then mobility of the patient post-operatively is reduced. Early rehabilitation is affected. So the recent advances which have come now and which are going to become, not come to India now till now because of non-availability of drug, but the future is the presence of genicular nerve blocks. Genicular nerves are the basically end sensory nerves which originate from the sciatic and femoral nerve, and they encapsulate all the sides of the knee. So there is a superior-medial, superior-lateral, inferior-medial and inferior-lateral genicular nerve. Inferior-lateral we don't give because it's next to the common peroneal nerve and it can cause foot drop, which will again hamper the post-op ambulation of the patient. So we give superior-medial, superior-lateral and inferior-medial blocks next to the genicular arteries. But this block again has to be given pre-operatively. So you need to have a drug which is act for long time. So there is the advent of new drug which is liposomal bupivacaine, which is still not available in India, but it is already in use now in US and other Western countries. In this there is a lipid encapsulation of the bupivacaine molecule, which allows to give analgesia for 72 to 96 hours. And it is available in 2 formulations. So when you combine this with genicular nerve block, the recovery and continuous epidural injections or catheter is not required in such cases. With all these things you need, as I said, it's a multimodal analgesia. Sometimes you are not able to control pain, then you have to give patient control analgesia in such patients. So opioids can be administered, then you calculate the dose of opioids over 24 hours and then you convert into oral analgesics. Transdermal patches can also be used, but if you want to use transdermal patches, try to apply before the surgery so that the effect is proper effect or best effect you can get post-operatively. Other things are the systemic drugs like acetaminophen, NSAIDs, opioids, gabapentin, even dexamethasone has, because of its anti-inflammatory action, reduces the pain post-operatively. Conclusion that optimal pain after TK is achievable in most patients, and we should use the things which are comfortable with the anesthetists which they are using day to day, and we should take care of the patient's co-mobs while determining the patient controlled analgesia in such patients. Thank you.